Okay, we're going to get started. We were just waiting because we know the exhibit hall is so far away that for anybody else to join. I'm Marina Kurian.
I'm Marie-Cécile Blanchet.
And I'm Lillian Cow.
Okay, and so this session is really just talking about the many different pathways to success. And our first speaker is going to be Lillian Cow, who is our past president of IFSO.
Well, thank you very much, and it is certainly my privilege to welcome you to this session, which is Women for IFSO and a Rocky Road to Success. So as far as this talk is concerned, I have no disclosures. And I'm going to start off this talk by saying that success as a woman surgeon, we need to redefine the achievements through personal fulfillment. And it's really beyond metrics. It's really what really matters to us as women surgeons. When I looked up Google and ChatGPT and I looked up who are the pioneer women surgeons, 3 names keep coming up. Mary Edwards Walker, and she was two centuries ago. She was the first woman to serve as a surgeon in the U.S. Army during the Civil War and was later awarded the Congressional Medal of Honor. Lillian Violet Cooper comes from Australia, and she was the first female Australian surgeon and a foundation fellow for the fellow of the Royal Australasian College of Surgeons. Then in the UK, Avril Mansfield was the first female vascular surgeon who then became the first female professor of surgery. The common theme with these women was that they broke barriers. They proved that women not only could do medicine, could excel in surgery. So they've really set the pathway. We probably don't realize it, but they really had significant barriers in a very male-dominated field in their time. There were societal expectations and, of course, even institutional discrimination. They describe difficulties in even obtaining their medical and residency education. And it's because of these women, their courage and perseverance, they opened doors to women like us, women in surgery, and with mentorship and leadership. This is becoming more crucial for us and for future generations for surgeons. So in my talk today, I'm going to challenge the traditional success metrics that we measure in surgery. I'll tell you a little bit about my personal journey and lessons I learned along the way. So when we look at definition of success, a traditional way or a personal way, the traditional success is that, whether you get the most papers, you work the longest hours, you have the biggest title after you, or you have the richest salary. Or if you look at personal fulfillment, what is the impact of mentorship for yourself and for people around you? How sustainable is your job? Do you get joy in your daily work, or do you feel rich in your life? So I would say that traditional success, if you pursue it in the traditional way, can lead to burnout and dissatisfaction. It may ignore your individual likes, dislikes, passions, priorities, and personal values, and often excludes the realities as we as women also need to do in comparison to our male counterparts, such as work-life balance and caregiving roles. If you look at your own personal fulfillment, do you lack your values? You need to know what drives you, what is your compassion, what do you love most, teaching, innovation, advocating for your patients, and you look at your strengths and what really drains your energy. So I believe success is like liking yourself, liking what you do, and liking how you do it. So the first step is look upon yourself. Look at your own values. What drives you? What is your compassion? Are you a leadership person or are you a creative person? You know, what drains you? What certain parts of your life you don't like? But what are the things that you are also proud of? And if you look back, what do you want to be remembered for? And also look at the things that are non-negotiable in your life, whether it's family time, your research time, or your love of teaching. And I believe you can actually align your passion, your purpose, and your practice. And I think you'll find success somewhere in the midst of that combination. And I like to say that a Baron's career is not about not neither or. You know, you can be a brilliant surgeon and a present parent, or you could be a skilled leader and a kind colleague, or even academically engaged and also feeling emotionally well. So balance doesn't mean doing less. It means doing what matters most. So I'm going to tell you a bit of my personal journey, and many of you will wonder, a diminutive person like me, how did I become a surgeon, let alone an academic surgeon, or even an IFSO president? So the theme that I find that drove me, or how I got to where I was, or I am, is about timing, just being in the right place, the right time. And sometimes you don't have to go and fight and look for it. It's just being in the right place. So many of you may not know, I actually was born in Malaysia, in a place called Malacca. And my parents, when I was in high school, moved to Australia, and a place called Adelaide. Growing up in Malaysia was a very different culture, because I lived in this place called Malacca, and if any one of you ever been there or even been on a holiday there, it's a very eclectic town. It started many hundred years ago as a sultanate of Malacca, and then with trade in the 15th century, the Chinese migrated to Malaysia, and then there was colonization over the last 300-400 years with Portuguese, Dutch, English, Japanese, and finally the Malaysian got independence in 1946. So when you grow up in a town with so many cultures that's come through, just living in a town, you see different architecture. So I'm going to give you an example. You know, the Chinese architecture is still there. You know, part of the town still have all these Chinese buildings. Then, of course, you have the Portuguese buildings around town as well, and it's very eclectic that you go to certain parts and you see these buildings that show where they come from. When the Dutch came, they left us the red buildings, and it's very prominent in the middle of the city. And then colonization with English, you have English architecture around the city, and today it looks like a modern city with pockets of different culture. And of course, then I moved to Adelaide. Adelaide is a town of about 1.5 million. We've got the mountains and the plain and the ocean, and therefore, for those of you who did come to visit us at IFSO in Melbourne last year, we do have beautiful sunsets. We also have some iconic animals that, like the koalas or the kangaroos, and we also, like Chile, have beautiful wineries. When I finished school, I did an undergraduate medical course at Flinders University. We had what we call instead of MBBS, it's called a BMBS. And then being in an institution with a lot of research, I was given the opportunity to do a PhD in neurophysiology. And whilst I was doing my surgical training, I completed my PhD and my surgical training together as a dual course, and got my fellowship, what we call a fellowship from the Royal Australasian College of Surgeons in 1996. And that's when my career started. So coming from Flinders University, I got a job in the Flinders Medical Center. My first job was the chief surgical resident, and then I became a consultant in 1997. Now, being a consultant, I firstly was in general surgery, but I had training in HPB surgery, endoscopic, laparoscopic, and did a stint of liver transplantation. I did my training in Birmingham, United Kingdom. Historically, again, being in the right place, the right time, historically in my Flinders Medical Center, our foundation professor, Jim Watts, believed in bariatric surgery. So every resident that came through, or every surgeon that trained under him, had to learn how to do bariatric surgery, of course, as open surgery to start off with. In fact, he did the first randomized multi-centered trial in bariatric surgery, looking at 3 operations: open gastric bypass, open vertical gastroplasty, and an operation that we don't do anymore, a gastrostomy. And this trial, he came to the conclusion that the gastric bypass was the gold standard, and every surgeon that came to Flinders Medical Center learned to do the gastric bypass as an open procedure, and so did I in my residency days. Then again, being the right place, the right time, the gastric band was introduced into Australia and into my institution. My current boss at that time, Professor Jim Tooley, he came back and he said, let's try this gastric band. And I was his registrar, and I therefore got to do the first gastric band in my institution with my boss. So as you know, historically, when gastric band was introduced into Australia, we were only doing several hundred bariatric surgeries per year. But over the next 8 years, it increased. It was very popular, and everyone wanted a gastric band, and so it increased exponentially. And the rest was history. Bariatric procedures in Australia increased exponentially. We did a lot of bands around about 2008, 2009. In fact, 95% of our operations were gastric banding. And of course, with the introduction of the sleeves, with an increase in numbers, and today, sleeve is the most popular operation in Australia. So when you become a bariatric surgeon, of course, you join the local society, which was AUSANS, is now called NSMOS, because we are combined. Australia is combined with New Zealand. If you're a woman and you are organized and you come and join the society, they'll tell you that, oh, good, come and do some work, be the treasurer, be the secretary, and then I rose to become the president. And then the Asia Pacific chapter was then formed around about 2009. And again, you're a woman, great, do some work, be the treasurer, be the secretary, and then I rose to become the president. And then very similar with IFSO, I started as the treasurer, then the president, and this year, chair of the board of trustees. In the meantime, in my home hospital, I became the clinical director of GI surgery and the clinical professor of surgery. But let me say, along the way, I had help, and I wasn't scared to ask for help. There are many of your colleagues, male and female, are there to support you and to help you, so don't ever forget that. And of course, help from my family. I have one son, that's Samuel, and my husband, Andrew. And because we have one child, every time we have a celebration, we invite all our friends together, and this is a celebration with one of my son's classmates. So, what have I learned along the way? Well, I think as you progress through your career and through your life, you wear different hats. You are a metabolic and bariatric surgeon, so remember you have unique technical skills, you have manual dexterity, you have clinical judgment, and as a woman, you have empathy. So follow this aphorism that I've always used. A good surgeon is one who knows how to operate. A better surgeon is the one who knows when to operate. But the best surgeon is the one who knows when not to operate. So how to be successful? I think you have to remember, first of all, you chose the career as a surgeon. You also chose the career of being a metabolic and bariatric surgeon. So that is your first job. So as you progress through your job, there are life events that you cannot ignore. Some of us find love, marriage. Some of us are lucky to be parents, so, when you are parents to 1 or 6 children, you will have problems of sick babies. Your babies will grow up to be teens. You may miss things at school, like parent-teacher meeting because you're stuck in theater, birthday parties that you may have not got to, or games or sport. But remember, also, you can have the ability of being a mentor, not only to your children, but to your colleagues around you. So it's a juggle, but I think at the end, you will emerge happy in the job that you do, and just know that you are a very unique person. So to finish off, I say to you, success in bariatric surgery, remember you are unique. You are unusual in the population of, around the world. You are different. You are a skillful person. You have advanced surgical skills. And remember, you can also change the life of your patient. So I believe I'm feeling very privileged to be a woman surgeon, and I'm in the leadership program. And I say to you, in your life, find a balance, work within your ability, don't go beyond if you cannot, and don't worry about it. Care about your job, forgive yourself if you miss things. Family and friends are paramount, and care for your patient. And lastly, you can also remember your patient, they can teach you a lot of things. I've learned a lot of things from my patient as well. So this is my last slide. Things to remember: appreciate the privilege of being a unique bariatric surgeon. We all work hard, so we accept our sacrifices. Care for your job, and it will care for you. Do your best. Friends, family are important, and be an example to others. Thank you very much.
So much.
Wow. I know. Okay.
We move on for the next presentation with Dr. Anne Rogers, Managing and Leading Difficult Personalities, Strategies to Manage Your Sanity.
I was assigned to talk on difficult personalities, and I wasn't sure it was about being one or managing one. I decided to go with managing one. So, difficult personalities. Oh, boy. They're everywhere. It's really funny. Rich people think money doesn't matter. Beautiful people think looks don't matter. Mama! Yeah, somebody who just killed a man thinks nothing really matters. Okay. But some things matter. Okay. We spend about 2/3 of our lives at work. And, at some point or another, you're going to discover people who are difficult. And you're going to have to figure out how to deal with them. I've had to, right? It's important. We hire people, we fire people, we lead them, we manage them. They're everywhere, okay? And I thought I would illustrate this talk with something that happened to me, and luckily it was some time ago, and I really biffed on this one, and maybe you can learn from my mistake. I had a bariatric clinic. I ran the clinic, purportedly. I had a nurse manager. We had a nurse practitioner. We had a LPN. We had 2 dietitians. We had a dedicated psychologist. And we had a front desk medical office assistant. Okay. Well, the nurse manager got sick of everything and quit. And so she disappeared. It took a while to replace her. We got another one. She got sick of everything. She disappeared. This happened over and over again. We went through at least 4 nurse managers in a relatively short period of time. And that should have been a hint to me right there that something was going on. But eventually, I got the brilliant idea of having my nurse practitioner take over that role, because she was perfectly capable of doing it, and she was already there, and that way I didn't have to wait for somebody else to be hired. And the difficult thing is that she was also, had become a personal friend of mine. Okay, so let's take a step back and think about personalities. Okay, and I've read a little bit about this. There's a 5-factor model of personality, and the 5 factors are openness to experience, conscientiousness, extroversion, agreeableness, and then we have neuroticism, and if you think about all these things, you can parse them out. There's a list of behaviors that exist, and these behaviors could be perceived as difficult within the workplace. And that's things like callousness, grandiosity, aggressiveness, suspiciousness, manipulation, domineeringness, and risk-taking. Okay, so, and if you like to have labels, there's a bunch of different ways you can think about people who are difficult in the workplace. There are people with narcissistic personalities. I've been married to one. These people have a big ego. They got to be the center of the attention. They could be charming on the surface. He wasn't. They can quickly become arrogant and cold. They're sensitive to criticism. They do not have empathy. And then there are people who are passive-aggressive and, they do not follow up on commitment. They sabotage other people to make themselves look better. They tend to perform better when you have requirements that are very clearly defined, absolutely direct. They're much better if they have boundaries that are given. And then we have people who are gossips. These people are very common, but it can be really toxic when it's allowed to be negative and uncontrolled. And this is particularly true if you have a bariatric program that's made up specifically of women. And this was true in my program. We didn't have any male employees in my program. It was all women, and it was kind of a very middle school atmosphere. It was a bunch of chicks, and there tended to be situations where one would gossip about the other and two would like it was a mess. Okay. There are anger addicts. They like to belittle people. They like to bully and undermine others. They can be quite aggressive. And sometimes their attacks can be kind of private and it's not obvious. And there are people that can guilt trip and they like to blame people, and it's always somebody else's fault. It's never their fault. Sometimes they actually out and out lie to avoid any consequences, and they just don't work well with others. And sometimes they pick a favorite target, and it's always that person's fault, and it can be really awful. So there's a couple ways of dealing with these people, and sometimes you just need to talk to them. And sometimes people who have problem behaviors it's because they have something going on outside of the workplace, okay? It may not be a specific problem to the workplace. They may have something going on outside, and if you sit down and talk to them and say, hey, what's really going on, you can help them realize that and try to provide solutions. And if you're just mean to them, or you're contemptuous, or you're aggressive, that'll often worsen the issue, and so you need to stay calm and try to find constructive ways of dealing with the problem. Another way is to separate yourself and find an external mentor for these people, because sometimes your employees have learned bad practices from some other job, okay? And it helps them not to hear from you, but to hear from somebody else that, this is just not a way to get along. And a third party is really helpful. I learned this when I had little kids. It always helps to have a third party, like, the dentist says you must do this, not I say you have to brush your teeth. The dentist says you have to do this. It helps to have an external party. Get assistance, get a counselor, executive coaching, whatever. But you have to do something, because if you do not address toxic behaviors, it's going to damage your practice. You simply have to do something. You cannot sweep it under the rug. You must do something to address it. So we're going to call this nurse practitioner Rhonda, because who knows, you may know this girl. She was very, very bright. She was smart as a whip. She was conscientious as hell. She was a baby boomer. She was about my age. Unfortunately, she was a little bit neurotic. She was highly aggressive. She was suspicious as all get out. She was quite domineering. She was quite grandiose. She had good points. She had bad points. This is one of her favorite things. I like it too. When things pissed her off, she would yell. And you know what? It does relieve stress and feel good. It is somewhat scary to birds. This was her default way of getting around problems that she did not like. She would yell a lot. Okay? I love this. Hey guys, I want you to get some shovels. Go dig some holes up there. I'll explain it to you later. I love it. So she would do the following. She would meet with me, and she would tell me things that would just make my blood boil. She would say, hey, the workers are always coming in late. They leave early. the phone rings and they don't answer the phone. It's constantly going to voicemail, so people want to come in and make an appointment. Nobody answers the phone. Oh, that would be terrible. She would say, yeah, I overheard a patient. She would call on the phone and she said there was crushing chest pain. They wouldn't tell anybody, and they would just, make a note of it in the chart. Oh my gosh, I lost my mind. And then she said, people are taking things from my desk. I'm not sure what to do. Oh, it's terrible. And then she would dig things up on the internet, and she would say, oh my gosh, look at this news story. I found out that this patient that you had, she murdered her husband. Oh my God. She was just constantly finding things on the internet. And then she would find out things about patients. She would meet with patients of mine and find out terrible things about them. And then she would say snippy things to them and set them straight. And it was always put in a way that would put her in a good light and the patient in a bad light. And so it just made her look good. But then if I heard about it from other staff members, what was really happening was she was telling them they weren't working hard enough, okay? And she would always cut them down about the way they were trying to solve problems. And she would find ways to tell them they were dumb as hell. And she would get angry at the slightest thing that she would perceive as a slight that really wasn't intended as a slight. She was highly territorial. If somebody even approached her office, she would lose her mind. And she was constantly on the internet looking up patients and staff members, and it just isn't right. She was quite judgmental and was mean. Okay, so this is a problem. So if you have a difficult personality in the workplace, it is going to decrease productivity. The entire staff is going to be stressed out. They're going to make mistakes. They're going to not show up to work. They're going to use their sick leave maximally. The staff is going to turn over, and this was starting to happen. I was having people quit. And then you're going to lose your skill and your knowledge. You're going to constantly have new people working there. And your whole reputation for your business is going to fail. So this is a problem. One way I dealt with it was to drink heavily, and we know I do this to some extent. But I should have considered other options, such as not putting a friend of mine in a management position. That was problem number one. I should not have done that. I should have just had her in an interim position, and I should have been actively searching for somebody else to take that job. I should have brought her in and said, hey, there are some problems going on here. You must change. You must change, or this is going to stop. I can't have this go on. You're going to lose the position. And another thing I should have done is been a secret shopper. I should have been the person calling in on the phone lines to see if people really weren't answering the phones or what the devil was going on. And so what ended up happening to Rhonda? Well, my staff realized that they weren't able to talk to me because I was friends with Rhonda. So they went around me. They went to HR. They complained about her. She was put on a performance improvement plan. And guess what? She completely failed to improve. And she was told that she was either going to resign or she was going to be terminated. She was allowed to resign. It took 18 months to replace her, and she had been essentially a good employee except for all these problems with the other staff. And so this affected me and the entire program. And so it also took 6 months to actually hire another program coordinator. So this put me in a very, very difficult position, and it was a serious problem, and it was a worse problem than it would have been if I had just waited and hired another program coordinator. So, and during all this time that she was working there, we went through multiple staff before we were actually able to right the ship. So, and by the way, I lost this friend who I really liked because of all this brouhaha. So it was just an unbelievably stressful time for me and for everybody else. It was unnecessarily toxic, so I suggest to me that I not let it happen again. I suggest to you that you not let it happen at all. And that's about it. Thank you very much.
Dr. Rogers, it's my pleasure to invite our next speaker, who is Marie-Cécile Blanchard, who is from France, and she's also the current president of the French Society.
Hello, everyone. It's a great pleasure to be here today in Santiago. The title of my talk may sound unusual, but it addresses a reality that every surgeon faces at some point, managing feelings of failure, expectation, and grief when things go wrong, how to avoid being the third victim. I have no disclosure with this presentation. I'm the current president of the French Society of Metabolic and Bariatric Surgery. I work in Lyon, the French capital of gastronomy, in one of the biggest private centers, and our team performs around 100 procedures each year with a specific expertise in outpatient surgery reaching 80%. So complications are part of every career surgeon, and there's a well-known saying, if you have never had a complication, it means that you have not operated enough. But when complications happen, they can be devastating, not only for our patient, but also for us as surgeons. Studies show about 30% of surgeons report symptoms of burnout directly linked to surgical complications or adverse events. And almost all of us, 84%, can recall at least one event that deeply affected both our professional or personal lives. So, if complications are inevitable, suffering doesn't have to be. It must be optional. What about definitions and concepts? When we talk about complication, we usually focus on the patient, the first victim, patient who suffers direct harm. And since Albert Wu's work in 2000, we have also recognized the concept of the second victim, healthcare provider who becomes traumatized by the event, carrying guilt, shame, and psychological distress. And for women surgeons, it can be a third dimension, what we might call the third victim. As women, we can face additional layers of emotional burden, the pressure of gender stereotypes, the need to reconcile professional performance with expectation of femininity, and the challenge of proving ourselves in a male-dominated environment. The impact of complications is not only clinical, but also deeply personal, professional, and societal. Second victim syndrome is not only an abstract concept, there are real manifestations, and main symptoms can be grouped into four main categories. The first one is emotional. Surgeons experience shame, guilt, anxiety, anger, shock, sometimes depression or fear. The second one is cognitive. There can be flashbacks, nightmare, ruminating on each detail of the complication, and sometimes even suicidal ideation. The third one is physiological. The body also reacts with fatigue, sleep disturbance, headache, gastrointestinal problems. And finally, behavioral. Some surgeons withdraw, avoid colleagues, and struggle with poor concentration and irritability. So this table is a reminder that complications do not only harm patients, they can also deeply harm the surgeon if the emotional toll is ignored. And I'm proud to present this study. This is the first study focused on second victim syndrome, specifically within a metabolic bariatric surgery. It involves 130 surgeons, all members of the French Society of Metabolic and Bariatric Surgery, SOFCOM. And this study shows how deeply complications affect us and highlight the urgent need for better support systems. So the results, emotions felt following a sudden adverse, are from almost all of the surgeons felt concern for the patient. More than half one felt guilt and anxiety. Many felt sleep disorders, reduce of self-confidence, and worryingly, Almost 9 in 5 considered changing job. So complications deeply affect both patient care and surgeon well-being. What about coping strategy? For many surgeons, there are discussions with colleagues and family, but for half of the surgeons, they fall into rumination, and only 3% seek for psychological help. These studies show both strength of peer support and gap in structured mental health resources. There is also a difference in the impact. Younger surgeons and women are more affected by serious adverse events due to two main causes. The first one is the lack of experience for young surgeons, and for women, the tendency to deal differently with stronger pressure and stronger emotional toll. So we need to tailor support, taking into account both age and gender differences. The main barriers to seeking help are heavy workload, macho culture, lack of communication, and fear to burden others. So cultural and systematic changes are needed, not just individual resilience. Now let me share a concrete example from my own experience. It happened only 4 months after I had started in a new position. As a young surgeon, I felt already a stronger pressure to prove myself. And during the introduction of the very first trocar, I suddenly faced with a potential catastrophic complication, an aortic injury. So at this moment, I was overwhelmed with shock, fear, guilt, and loss of confidence. I remember thinking I felt my patient and my team will never trust me again. So what changed everything was the reaction of my colleague. I received immediate support of my team with rapid management of the bleeding, which saved the patient, and later during a debriefing, who improved myself. So the two lessons after this event for me was first, the importance of the teamwork, even in the hardest moment. It can save both surgeon and the patient. And later, the debriefing is very important. And the second lesson was that we must not left alone a young surgeon after a complication. We need to talk, to share, and to transform failure into growth. So to conclude, I will give you 3 tips to cope with guilt when things go wrong. Tip number 1, acknowledge and accept your emotion. By naming them, accepting them, this is the first step to healing. Tip number 2, do not face it alone, seek support. Share your experience with trusted colleagues inside your team or outside, even why not in this group, Women for If So. And tip number 3, learn but don't self-punish. Debriefing can help improve. It is a part of success. Complications are part of surgery, but they do not define us. What defines us is how we cope, how we learn, and how we support each other. By refusing to be the third victim, we can transform pain into resilience and isolation into solidarity. Thank you.
Okay, next we have Ana Carolina Batista Dantas to talk about obstacles to career advancement and how I managed.
Hello, good morning. It's a pleasure being here in such a prestigious group with role models and mentors. I think this is a very prestigious invitation, but a very difficult talk to talk about personal things. And I think Professor Lilia, she talked very personally about her life. I have no conflicts to disclose. The thing about us as women, we face difficulties that other surgeons have faced, but mostly we are expected to carry the weight of our decisions. Like, you chose to be a surgeon, it's your fault, you have to carry this. You chose to be a mother, it's your fault, you have to carry this, and so on. So despite male surgeons having difficulties also, we deal differently with this along our career. So the first thing I would like to talk here, it's imposter syndrome. This old friend we had during medical school, we had it during residency, I have it now. So it's very difficult for us in a male-predominant place to be sure of ourselves. We're usually the only woman in the room, so it's very nice to be here today. We face underrepresentation in our training, in our hospitals, in our surgical teams. We are in a room full of women here, but most of us work in teams only with male surgeons, and this gives us the need for a space like this to talk to other women surgeons. There are systemic factors in the hospital itself, in our society, and our own internalized bias. When we are in a room where you're the only woman in the room, do I belong here? Am I good enough to be here? Can I handle this situation? So how to overcome? Most of our mentors are also male mentors, so find mentors who champion women, who give you support, work with friends. It's very important to be in a good surgical team, in a good workplace that understand your specific situations of a woman when you have a child or something, and find your peers, your friends. My friends are here. We have a very strong group in the Brazilian Society of Bariatric Surgeons, and we became friends throughout the years. Another obstacle is maternity, of course. Not all of us wish to be mothers, but for those who want to be mothers, we have to deal with fertility issues. We have age issues. You're 35, you're almost 40, and you have to decide if you want to have children or not. And there's higher obstetric risk for surgeon mothers, higher rates of complications. And there's a lot of, we lack support. We lack support from our jobs, from the hospital. I was an alien in the OR. Even the nurses, they had children, they were pregnant in their lives. They treated me like something different. I had to sit. They were always offering me water or something. Are you okay to do the surgery? Yes, I'm okay. I know my body, I'm okay. So it's very difficult to be a pregnant surgeon and to be a surgeon mother. We have to worry about very specific things that we have no one to talk about, to ask. Our male partners, surgeons, our friends are male, they didn't get pregnant, so you have no one to talk about. And again, that's the importance of groups like this, to share experience and about pregnancy issues. And how to overcome, try to plan, save money, it's important. Plan your job, find someone to fill your job when you're on a maternity leave. Respect your body, know when you can operate to the end, or when you can come back after maternity leave. And embrace your support network. While you don't have support in some aspects of your job or your life, you find support in other instances, in people you didn't even know. Mostly male friends, your boss, your teacher, your colleagues, your spouse. And one great thing that I took from maternity to my personal life and professional life, we have to learn to prioritize. So we become very productive in all other things, academic things, and your working hours, because you have so much more to deal with that you learn to prioritize and enjoy. I don't like going to the beach, but my son does, so I wear sunscreen 99 and then I go. And there are some things that we don't control. There is uncertainty. And this is not only for us, women, but for everyone, for our male friends, surgeons also. Some things you can control, like COVID pandemic. Many of us were growing on career, were doing research or robotic training, and we lost everything. We had to stop. We had to change jobs. Sometimes if you're not a mother, you don't have to take care of children. You have to take care of someone in your family. Most of us as women will take care of for an elderly parent, your mother, your father, a spouse. Or sometimes you just want to change. You want to change your life. You want to change the city you live with. And I had to face the situation a few years ago when I decided to go back to my hometown. And after working 10 years in the biggest city in Brazil, the best hospital in the country, I decided to leave. And everyone was like, are you crazy? You're ruining your career. You're leaving the best job in your country. For me, it was just a job. I learned to prioritize my life, and I chose to do things differently. And what I learned with that, I embraced the change. I gave a new aspect to my life. I found new friends. I was closer to my older friends. And with my new life, I could focus on what I like the most, like teaching and working with residents and medical students. I could participate more in society activities. I had more time. Before, I was in the hospital 24/7 working. So adaptability is a strength, not a problem. We learn a lot from that. And to finish, I like this famous sentence from Marie Curie. She says, life is not easy for any of us, but we must have perseverance and above all, confidence in ourselves. I think it's essential to have confidence in ourselves. And I want to thank my friends from our group of Brazilian surgeons. They're all here. Thank you.
We're going to have a slight change because Dr. Salmonen has to go to a different session. So Paulina will be discussing how to successfully make research a part of your career.
Let's get the slides. You need to take the last presentation because we swapped, so. Well, I'll start before you get the slides up. Thank you very much for this kind invitation. And the question is not really that easy. It is, I have to be honest, it is very difficult, but it's doable, so it can be achieved. There we go. Now it's looking better. My personal disclosures. Now that we're getting it started, I see it already here. So there you go. Alrighty, awesome, thank you. So I would say this would be my simple answer. And this is actually what happens in real life. I just unfortunately heard the last talk. So 100% clinical work and 100% scientific work and 50 to 80% some other work you do within the societies. And all of those are equally important because you really benefit from networking and getting to know people. It's always, I'm a firm believer of 1 + 1 = much more than 2. So working together we are much stronger. But that's actually, you have to be really organizational to fit all of that into your schedule, and you have to have a focus. And again, earlier in your career, it's kind of hard to actually right away have a focus, but you have to keep it in mind. You have to do stuff that you are broadly enough engaged, but still at some point you do have to find your focus. These are my disclosures, and doing this presentation, I actually realized that this is probably the first talk that the majority are actually relevant disclosures. So I work as a full professor at Turku University Hospital. I have a private practice, and I teach, of course, the residents, and then I do my research there. I'm the primary investigator for the sleep pass trial, and then my other surgical research life is on acute appendicitis. So I have those two topics that I also do in my clinical practice. And we go back to the surgeon scientist idea. Then I'm also very active in journal work, which means that, that really helps your research career because you learn more all the time. And of course, research grants are kind of relevant here. So I'm just briefly in these 10 minutes going to run over the idea of, not to say that we're going over how to do good clinical research, but I think that if you do decide to spend some time there, you should really make that time worthwhile. So do not concentrate on lower quality research. It's much better to do one good study instead of 10 not so good studies. So really make your time, the time you spend, really make it count. I will just briefly show how I've incorporated these topics of research into my career and how to combine. I wish I would have a very good answer for this last question, and I can just tell you my personal experience, what I have done, and it's a very hard equation. I also have 2 kids. They're not as small. My son is 24, and my daughter is 28. And in spite of me, they turned out really good. So just to remind you of the hierarchy of the scientific evidence, because within, I think, metabolic bariatric surgery field and everywhere, but we need to be really aware of the fact that in the era we live in, we really need to have a high quality research in order to keep metabolic bariatric surgery up in focus. And conducting a randomized trial, which is the top of the pyramid. Remember, all the meta-analysis, even though you see a bunch of them, they are just a combination of the RCTs available. And if the RCTs are not higher quality, of course, making a meta-analysis doesn't really matter. So you do have to put time, money, effort into that. And it really is sometimes like an amazing race, like a lot of hurdles, brick walls and hurdles, but still please aim to think that however you do it, if it's not a randomized trial, please concentrate on prospective cohorts. So like I said, make the time you spend count. And if you do decide to do an RCT, please consult the people that have already done RCTs, because most likely they've already made all the mistakes. So please don't repeat all of my mistakes. Learn from them and from everybody else that does it. So make that time count. I will just say that this is here because I wanted to remind you, this is the story how the sleep pass trial began. The tall colleague is unfortunately already passed away. But he was the one that we designed the sleep pass trial with, and that napkin shows that, networking also outside Congress hours is very important, because we were sitting at a bar counter at 1 a.m. doing the flow chart. Unfortunately, that's not the original one, and I will show you a bit later what happened to the original one. You also have to have a bit of a luck when you look at metabolic bariatric surgery worldwide. What happened? 2014, sleeve became the most common procedure. And when you look at our recruitment for the sleeve pass trial, we started the recruitment at the time that they were not doing sleeves. I often get asked that, did we kind of see this happening? No, it was just, we were just enthusiastic about exploring that. I wish I could say that I had the crystal ball, but no, we were just enthusiastic to explore this new procedure. So keep an open mind. I think that's very important. And then I will just briefly go into the appendicitis, not the results, not the studies, just to show you the idea, because like I said, my other field is, and this is more of being a surgeon scientist, and we really need surgeon scientists, meaning that people that do clinical work, they actually know how to ask the right, correct questions and state the hypothesis. So here we have a disease that automatically everybody thought that, you always have to operate. We now know that you have two different diseases. You have the complicated one that actually needs an operation, and the uncomplicated doesn't. So we started by comparing surgery versus antibiotics for the uncomplicated one, showing that the majority can be treated without. We then continued to assess how to optimize the antibiotic treatment because, of course, we already knew what happens with surgery. We then continued to assess whether we even need antibiotics, and the pilot RCT showed that perhaps not. And here we are again on ladder number 3. So we're building on the shoulders of the previous trials that we made, and currently we are recruiting over halfway APAC number 4, comparing oral antibiotics versus placebo in a double-blind setting, and the patients are discharged from the ER. So just to kind of show you the idea that when you are doing that clinical work, you are also able to ask the correct questions. It is teamwork, that's definite. This is the one I'm going to show you what happened, actually really burned both of our appendicitis papers and that napkin at a hospital fire we had in 2011. So stuff happens that you really don't perhaps understand. And I would really, if you decide to do a trial, you have to be really aware of the acronyms, but that's outside the point. Clinical surgical science really goes to the national and international collaboration. Like I said, together we're so much stronger. And here I collected, to finalize my talk, I kind of collected the ideas that what I think I've learned along the way. I really firmly believe that we need all the surgeon scientists we can get. So please, if you find that interesting, find a good mentor, find a good group. You have to work hard, but combining clinical work and science is actually very rewarding. And you have to be curious, like appendicitis, the whole appendicitis research continuum actually now ends up showing that the 130-year paradigm of operating all appendicitis patients is actually not true. So, and I always say that we can use that saved OR time to actually do something of meaning. So, for example, metabolic bariatric surgery. So we do need to scientifically robustly assess different kind of eminence-based truths. So please do collaboration. That is a win-win situation for everybody. And remember to take care of your family. Like I said, my kids turn out, in spite of me, they turn out nice. I always tell my PhD students that you may go home a bit later, but when you do go home and the kids are small, then you cannot work. You get the kids to bed, you are there when you are there fully. So try to do everything you do 100% at that time what you're doing. You can maybe then work a bit later after the kids have gone to bed, but you really have to make sure that you are present also there. And that requires, of course, just clear organization. You need planning and you need perseverance to be successful. And I would say surround yourself with people who are smarter than you and learn from them. So focus really, if you do research, use your time well. Do not use your time for research that really does not have any impact. Make sure that you do. It doesn't mean that it has to be an RCT that's published in top 3 medical journals. That's not what I mean. A research that is high quality and actually contributes to the field is what I'm talking about. And be prepared. So at this point, I would like to thank both of my study groups. This is our last PhD dissertation. That's the sleeve pass, and this is the appendicitis group, and welcome to Malaga next year for the IFSO European meeting. Thank you. Do you want to have like a few questions? That's okay.
Yeah. Do anyone have questions for Dr. Salmonen? Otherwise, she's going to run, and I'll give the last talk.
My apologies. I have another session that I'm supposed to be chairing. Thank you so much for having me here.
Thank you. And let me introduce Marina Kurian for a communication adapting to changes in clinical practice.
Okay. I'm going to run through this, but I did not put a disclosure slide in, but I'm going to tell you my disclosures. I do speak for Medtronic, Ethicon, and Stryker, as well as Novo Nordisk. I do lectures for them. Okay, so adapting to changes in clinical practice. I looked at this in a couple of different ways. One, I was looking at it as the actual type of practice that you have. And we're international society. There's so many different ways to practice the art of surgery that it's hard almost to say that we're all going to have one. And I limited it to 3, but I'm sure there's a variability in all of our practice. How many of you are in private practice? And how many are considered academic? And who's in between? Yeah, see. And your in between is going to be different than someone else's in between. So I've had the pleasure of doing every single one of these roles. I started out in what we call community practice. Let me see here. Yeah, this is my history. I started out in a community practice in a smaller hospital, but in Manhattan. And I was salaried with a bonus structure, okay? When I first went for the interview and to get this job, the COO said, "So are you going to be part-time?" And I was like, "Why would I be part-time? I'm going to be full-time." And he knew I had a baby and all that other stuff. I'm like, "No, I'm going to show up next week and I'm going to work every day of the week. I'm not being part-time." And that was important to me because then, the harder I worked, the more I could make as well, which was important in terms of trying to stabilize my life after residency. Then I moved to academic practice, which was salaried, and there is a bonus structure that was a little bit different than what I was in community practice. And also, when you're an academic institution, you pay a tithe or a tax to your dean, to your Department of Surgery, and sometimes also to your chairman. So sometimes it comes to be 15 to 20% tax that goes off the top to the department. And then in private practice, I'm covering my own overhead, and most of the time I'm making a salary, but some months I don't. And it has a lot to do with how revenue stream is, et cetera. And those of you in private practice can sometimes, you see that the numbers go down or something, and then this all happens. But I want to run through some of the pros and cons as I saw it, and I, of course, welcome hearing about your thoughts later when it's a question and answer time. But for community practice, for me, it was more control over my practice. I did have some hire and fire control. Dr. Rogers was talking about her staff and replacing, but you can have a little bit better opportunity to safeguard your office or improve the throughput for the patients, and you can really address your work environment. And you are a big fish in a small pond when you're in a community practice like that. There are less resources to publish, especially if there's not medical students or residents that are in plentiful supply, as they can be at an academic center. And then, that should have gone under cons, guys. Sorry about that. But anyway, cons, less advertising dollars when you're in a community practice, less control over who the system is sending patients to, because it's not as much a mandate as it is in an academic institution that you have to send their patients to the academic surgeon. And then also perhaps a less capacity to do complex cases. That wasn't my experience, but I know that there are plenty of community hospitals or smaller hospitals where they don't have all the infrastructure and are not able to do complex surgeries. And in academic practice, there are a lot of pros. There are more advertising dollars, and a lot of times the advertising dollars are for the overall institution, but that does impact even your practice. There's more control over the system referrals, so you are getting a more consistent stream of patients coming to you. And then, of course, there's, as I said, more capacity to do complex cases, and there are more resources as well as a mandate, which you could look at as a con, but there is a mandate to publish as well. And the cons are less control over how you run your practice. When you're an academic institution, it's more of a corporate structure, and you can't just hire and fire someone. There's a lengthy process with HR or human resources to try and get the patient in and out. Then also, you are a small fish in a big pond, which is expected. Private practice. Well, I have infinite control on my practice. I have the ability to hire or fire anyone, and it depends on where you are. I don't have to leave a trail. It's a no-fault state, so I can just fire someone if I want to. I do have control over the advertising dollars that are necessary to maintain your practice, which is important. And then in private practice, I'm solo private practice, but I have help at both institutions if I'm doing a complex case. But it can impact other people's ability to do complex case also, because if you have, as a private practice person, if you do a lot of complex revisions or tough cases, that can affect the perception of your outcomes, right? Because not everybody is looking at the acuity of the case, they are only seeing the complication. The cons, in private practice, I know some really big names. We all know them. And so is it a big pond or a small pond? It doesn't matter. I think it just depends on the environment. Again, very little control over system referrals. I rarely get patients directly from either. I'm at two different places, actually, directly from physicians that are employed by those two different systems. And us being bariatric and even general surgery, a lot of the patients are self-referred. And then you also have to spend a lot of time, what we call pressing the flesh, shaking hands, calling the doctors to let them know. It's an important part of your practice, whether it's academic, community, or private. You have to reach out, but it's very important when you're in private so that it doesn't look like you're not there and doing the follow-up. I also wanted to speak a little bit about adapting to trends in surgery, because this has changed all of our clinical practice, although I've been talking to my colleagues around the world, and not everyone is so affected by the GLP-1s, but we have been in the US, and I know also in Mexico and Latin America. I don't know, you guys would be able to answer better too. But what's happening is you have to adapt to that, and while my bariatric numbers are down, my revisional surgery, and this is something that I find consistently across the US, the revisional surgeries went up for everybody. General surgery elective cases is up in my instance as well. Other people have gone to acute care surgery, what we used to call being on call, but now it is an entire profession of acute care surgery, right? A different specialty. And then maybe it may be in this time of diminished bariatric numbers, and I used to be 95% bariatrics, that's what I said, but really I was 99% bariatrics, but I didn't want anyone to think that I lost all my stuff, so I still said 95, but now I would say I'm 40% bariatric, and the rest is general surgery. But during this time, I've seen some colleagues have to transition, because I've heard of people not having their bariatric job anymore. And so they've been forced to transition, whether it's going into general surgery, doing traveling surgery, or looking at other opportunities like becoming a medical director or working for pharma or industry. So those are changes. So to conclude, I want to say there's no right way to do your clinical practice. I think someone else said, you have to do what's right for you, and, do what works for you and in the phase of your life, right? Because when I first started my career, community practice was great. I had 2 small kids, and I was not going to publish a lot. And it wasn't until later that really my publications took up when I switched to academic and my kids were older. But know that wherever you are right now may not be where you will be in the future, and that's okay. And it's better not to plan your life for 20 years. It's better to look at it like, here's these 5 years, and then the next 5 or 10 years. Thank you. And I'd ask all our other speakers to come up, perhaps, and someone can come up here, and we're happy to take any questions that you all may have. Anyone?
I'd like to say that I'm delighted to see so many women surgeons in one room, and men as well. I don't think this has ever been happened before. I've been to many meetings for IFSO, but I think this is a record having all of you in this room. So I hope you didn't mind. I did take a photo of all of you as a crowd, and I'm happy to share it because I think we have made history today, having so many bariatric surgeons, women bariatric surgeons in the same room.
Anybody have any questions? Those mics that was my timer for 10 minutes. I was trying to.
Or do ask us some questions or share your stories. Please do.
Yeah.
This is what it's all about.
Yeah. I think Marie-Cécile's, I didn't realize that they had that second victim paper, and I think it's so important to discuss it. And I really loved your talk because we all have had those moments or bad outcomes, and my friends would check in like if I had a complication. I know I don't have that many, which is why when I do, I freak out, so they're like, you're gonna be okay? I'm like, yeah, I'm gonna be okay, it's all right, but it is good to have that and to discuss. And I think the debrief aspect of it, where you just discuss what happened without having a blame or a shame, because this is going to happen. You know what they say, right? You've all heard this. If you've never had complications, you've not done enough surgery, right? So it's going to happen.
And the worst part is they do say, don't talk about it to anyone.
Oh, yeah,
Right?
And that's not, actually our institution has, I'm on the, of course, classic. Our institute, NYU, has this thing where if there is a complication, they will assign you someone to speak with you about it. And so I did get called and asked to speak with someone who had a complication, and I tried to call and email, and I did call him. He's like, I'm fine. I'm all right. I don't need to do this. I was like, okay, that's probably not fine. But anyway, Sarah?
Hi, thank you so much for putting together this excellent session, excellent talks. Appreciate creating that space for all of us to accept that it's okay. There are certain challenges that are gender-based, and so thank you for doing that. I'm Sarah Samreen from US. My question to all the panelists, how do you navigate pay parity issues? Even when you take away things such as maternity leave and less RVU production, and of course that's based for people who are in an employed model, if that's a community practice or academic. Same way, we know ASMBS has a survey, I'm not sure if at a IFSO level this has been looked at, that women make less money than men, all things equal. How do we deal with some of those issues, and how do you talk about money in a non-threatening way where then you don't get fired from that job? Thank you.
I can't answer this because I just tell them I won't accept less, and I am threatening when I do it. So I can't say that I know. You guys, I knew for a fact that I was paid appropriately. But
Yeah, I took a job right out of fellowship, and it wasn't like I was a new fellow. I'd already been working somewhere as an attending for 15 years, so it wasn't, and they had done a search and they had offered a job to somebody, and I knew that the salary they offered him was already much lower than was ridiculous. It was absurd. So I said, no, I'm going to need, and I named a salary that I knew was much more in keeping with what was acceptable. And they were shocked and appalled, and we went round and round, and they finally gave me what I asked for. So you just have to know what you're worth and wait long enough. But it's a question of asking. You don't just accept what they say and then feel bad about it. You tell them what you're worth, and eventually they will give it to you. And it's uncomfortable, but that's what you have to do.
I think in this modern era, equity in pay should be similar whether you're a man or a woman. You know, particularly in our field, as women surgeons, you should be paid exactly the same as your male colleagues. And I see that in Australia, that is a job. Whoever takes the job gets the pay. However, of course, you know, sometimes we do take time off for whatever reason, having children. I see my male colleagues taking paternity leave, so they are also taking a pay cut for, you know, having quality time with their family.
Hello, I'm Dr. Abreu from Panama, in Central America. I need to tell you that in Panama, we have the same salary, females and male doctors. It doesn't matter. But there's something that is giving me some hope, and it's the fact that it's proven that in the last years, there are a lot more women studying medicine than men.
Right.
Men are selecting different careers, shorter, and they will believe that, I think they believe that they will make more money rather than studying a very hard and long career. So women are being now getting into medical school and getting into fellowships and other things, and they are doing things right. And in 5 years, I hope we won't have this small room without translation and everything. We'll be in one of the big ones and we'll do everything very well, because now we are the power behind the doors. So congratulations for doing this. It was very nice. Oh, well, I mean, my husband cannot live without me.
Okay.
I would like to make a question to the audience. We talked about the second victim. It was a great class. And today we have a lot of sharing information and expertise in social media. Do you talk about complications on social media? Or do you pretend it doesn't exist? Or if you talk about complications, how to address in a way that it's informative, but it doesn't scare the patients? That's a question I don't know how to talk about it on social media.
How to talk about complications?
On social media. Do you talk, and how to talk?
You mean when you're explaining risks to patients?
Yes.
Oh, okay. I don't know. I haven't ever done it on social media. I mean, I've done like little YouTube posts when I talk about stuff, but that's for my patients. It's not out there. So some of you guys have big, you're on Insta or TikTok. Monique, are you on TikTok? Do you talk about complications?
About specific complications of obviously my procedures. I have been focusing a lot of my social media really on more awareness and stigma rather than talking about the negatives of our surgery because there's so many more positives. And you know, I think that that's what patients want to hear, at least my following. I feel like that's what they want rather than talking about the negatives of, you know, leak and all those things. And it's also less than 1%. So it's, you know, why are we talking about something that's so low? So.
Good morning. My name is Karina. I'm from Brazil. My English is not so good from the Carolina, but you can help me if the people don't understand me so much. I think the answer for that, what I do in Brazil, it's we don't have to say, example, look, you can have a fistula, you can have something with your surgery. But the best thing that you said is, look, the chance of to you have something wrong with you, it's sorry, the best way is like the best thing that you can do is 98% of good answers, good results.
Right.
You don't say that. You can bleed, you can death, you can, no. You have to say the best.
Right.
In Brazil, you said that you are there to sell, okay? You have to, it's a product. You are in the social media for that. You are a product. The bariatric surgery is a product. When you at McDonald's, in the product in McDonald's in TV, you don't say in the McDonald's, you don't say in the TV, McDonald's give you a get weight and etc. And why we have to say a bad of surgery? No, we have to say that we save lives. And I think it's a way to think about it, okay?
Yeah. Yes, we all understood your English perfectly. Thank you. Thank you.
The thing I worry a lot is because there is a lot of misinformation from patients, especially on TikTok, about complications. So how can we fight this misinformation if we just don't address the issue? We don't talk about it, never.
I think we have to control the conversation. And instead of talking about specific complications, we should say, yes, there are horror stories out there about bariatric operations, but that is because there's so much stigma about obesity. There's just as much stigma about obesity surgery. And so if you go out and look up any operation, such as facelifts or tummy tucks or anything else, you will find somebody who died from some operation somewhere. And that's just because it can happen. But we can look ourselves in the mirror because for the most part, we're doing good for people. And they have so much success because of this, that, and the other thing. Bring it around to what we do that's good.
Yeah, agree. Good morning, everyone. I am Ana, also Ana Carolina from Brazil. And I guess maybe not addressing the complications itself, but what the patient wants to know from us is that we will be there for him or for her. So maybe we should address like that. Well, it's mostly good and you have a huge chance to go fine, 98, 99%. But if you are that 1% that doesn't go fine, I will be there for you. I will hold your hand. And as women, we do that in a brilliant way. So I think that's it.
Okay. Any closing remarks, ladies? Oh, perfect.
I was so confident back there, and now I'm nervous. Hi, everyone. It's so weird talking backwards, but I'm Giovanna. I'm from Brazil. I'm feeling a little bit imposter syndrome here because I'm a medical student. I'm not a surgeon. Welcome. I don't know how to say. I'm so nervous. I'm here to present 3 papers of mine, and as a medical student in Brazil, I'm very glad that I'm here listening to all of you, because I don't know how it is otherwise in other parts of the world, but in Brazil, we don't have a lot of
role models?
No, it's not. Yeah, it's not like motivation, because we do have this, but we don't have the money. You know, we don't have the money to perform real good science there.
Yes.
We do have.
We don't have.
But
We don't have grant.
A lot. Yes, grant. This is funding. We don't have funding. The same way that Europeans and North American have, and it's very nice to be here to listen to you, because something that I don't know, a few of us learn in Brazil is to perform systematic reviews and meta-analysis, because this is the high quality of evidence, so we can put ourselves in places like here that is not talked about in my country. And I also have a company about medical educations, and I really want to ask to all of you, how did you, if you can share a little bit with us, how did you get through all of the little rocks, you know, in the way to become a model in your country, in your career, like how it was for you to be here? What can you teach me about this, about be strong and be tough to face things, because it's really hard there. we don't have a lot of funding or motivation in a few ways, and if you are in the wrong university, you don't have science applications, like, you know, science funding.
There is only one word for this: passion.
Oh yes.
Sometimes you have to be creative in your search for funding, right? If you're doing something, you can sometimes apply for a grant through an industry. You can apply for grants through the society sometimes. We have at ASMBS, and I know IFSO also has research awards. So your surgical societies would also have it, not just the metabolic and bariatric. But that's one way to do the funding. Instead, not everyone can be an R01, NIH, K8. Those are just letters to me. I have no idea. I just know an R01 is hard to get. But I think that there are other sources for funding. And actually, Dr. Rogers has had tremendous amount of money from different, for research.
I've had very little funding, and I mostly used medical students. And so I signed up many, many medical students to make REDCap databases and to get together as a group and go out and do the work. And then they published with me. And then they were here presenting 3 papers and things like that and getting their names on papers. And, so I was able to support them and they were able to support me, and we worked together to get things going.
But I'm just trying to figure out I know everyone's used to me being on my phone, but this time I was trying to figure out where the networking lunch, if it's outside? Huh? No, but we were going to do it here in Hall A. So
I think it's another room G.
Oh, room G?
It's on the
app.
Stephanie sent on the WhatsApp group the flyer. I think it's room G.
Oh, okay.
That flyer on the...
It's upstairs? Okay, so there's a networking lunch, and it's in room G?
Before we finish up, we have the photographer here.
Oh.
Shall we take a group photo?